Wonderful. Good evening, everyone, and welcome to the National Spine and Pain Center's Clinical Development Webinar Series. We are so excited you've joined us this evening. We're going to give everyone about another minute or two to log on. So again, welcome to the National Spine and Pain Center's Clinical Development Webinar Series. The webinar will start in just a minute. Good evening, everyone that is just now joining us. We are welcome to the National Spine and Pain Center's Clinical Development Webinar Series. The webinar will begin in just about another 30 seconds to allow a few more people time to log in. Again, if you are just now joining us, welcome to the series. We will begin in just a few moments. Good evening, everyone, and welcome to the National Spine and Pain Center's Clinical Development Webinar Series. I would like to introduce our moderator for the evening, Dr. Peter Stotz. Dr. Stotz, go ahead and take it away.
Welcome, everybody, and welcome to what I believe now is our fifth in this National Spine and Pain Clinical Development Webinar Series. And every time we do this educational symposium, we bring in some luminary from administration or some other area to talk about something that's relevant to you. We also have several presentations on clinically relevant topics that I think are going to be very exciting. Tonight, we have four excellent speakers, Bill Kolazar, Ketan Patel, Asaf Gordon, and Sean Lee, covering marketing, the coronavirus, our outcomes research plan, and one of the most new and exciting areas of pain today, which is peripheral nerve stimulation, and how we can all be part of the solution here. I am not going to have our normal chit chat because there's so much to cover today, and I'm going to, with great excitement, introduce my good friend Bill Kolazar. For those of you who have not met Bill, Bill is our Director of Marketing, our Chief Marketing Officer here at National Spine and Pain, and was one of the, what shall I say, unexpected, real pleasant aspects of this job is getting to work with Bill. He is a consummate professional, just a wonderfully nice person, understands this field of marketing like we all understand medicine, and is going to apply the modern science of marketing to our practices. And I asked Bill to come today and talk about how he does this, what's he doing for you, what is the approach, with an encouragement for you to get to meet Bill tonight. Reach out to Bill if you have particular issues or areas of concern for your own practices and ideas on way to push your practice forward. But with that, I'm going to turn it over to Bill. Bill.
Outstanding, Peter. Thanks so much for the introduction. I get the sense that maybe my mom sent that to you. It was so nicely worded and complimentary. I can't thank you enough. Let's jump into it and talk about marketing, and specifically marketing within the realm of National Spine and Pain Centers. Michelle, if you could hit the next slide. Outstanding. So Peter alluded to it. One of the things that has changed dramatically in marketing over the past few years is a much more data-oriented scientific approach. You know, if you go back to Mad Men, the AMC series where, you know, advertising executives were lounging around the offices, drinking scotch and coming up with big ideas. You know, that's the old world. That literally is the 1960s. In the 2000s, we have a lot more at our disposal, and the people that were right-brained and totally creative have really kind of fallen by the wayside. To survive in marketing today, it takes a left brain and a right brain and a scientific approach. And so I'll give you a quick overview of some of the ways we go about the tasks at hand, and then I'll actually show you some of the data we're using. In general, our primary objective, you'll be glad to know, is to drive incremental patient volume to you. You know, I get up every day, excited to help people understand that there's this entire discipline of medicine to help them deal with pain, to avoid pain, to get relief from pain. And early on, when I joined NSPC, we did some focus groups that showed that a typical patient, doesn't just show up at a pain management office. They typically go through anywhere from 3 to 10 stops along the way. I know you've heard these stories directly from patients. They go to primary care, and then they get bounced to a physical therapist, and they go to a chiropractor. They don't like that chiropractor, so they go to a different chiropractor. Then they go to an orthopedic surgeon. The orthopedic surgeon says rheumatologist. Rheumatologist finally gets them to you, or they do their own research, and they find you, and you help them, and you relieve their pain. Well, there's a way we as a marketing team and as an organization can find those people directly and more quickly to shorten the time frame that it takes for them to go through all those rotations. And specifically how we do that is through data science. So one of the first things we did when I joined NSPC was we analyzed literally hundreds of thousands of existing patients. We actually bought data in the open marketplace and appended that data to our own patients. So not only did we know already their name, their age, their address, their conditions, we also began to learn what their hobbies were, what kind of cars they drive, what goes on psychographically in their minds. And by understanding that among our current patients, that enables us to go out and buy data to target prospective patients that look and act demographically and psychographically just like our own patients. So we're essentially using data science to understand our patients and then go out and find more that look just like it. One of the interesting things we found, particularly with our regenerative patients, so they tended to be more affluent because it's cash pay, of course, and it's not inexpensive. They tended to be into hobbies like aviation and equestrian arts. So slightly higher end patient than we would normally see. The other thing we're able to buy in terms of data that helps us target prospective patients is transactional data. Now, we don't see the actual transactions, but we get indicators. So as an example, think of someone who bought a lidocaine patch at CVS, and then they bought a foam pillow on Amazon, and then they had a copay at an orthopedic surgeon. Well, cross-triangulate that data, and it suggests to me that's a patient in pain. That's a patient that's looking for relief. And so that is an example of a household we might buy the data. We would buy their physical address, the right to market to them in their physical address. We'd also, along with that, buy the right to market to them across platforms. If I have your physical address, I can also target you on your mobile device. I can target you on your social media accounts. I can target you on your IP address for your laptop or your tablet. So that's how we're going about targeting both patients and past patients. Doing it in a couple of ways. One I just mentioned, it's called integrated marketing. It's going across different channels, whether it's your tablet, your phone, your social media accounts, a physical mailing to your house. And then we also invest significantly in pay-per-click and display campaigns. So if you are searching, say, back pain relief, if you are searching that on Google, there's a good chance if you live within a very short distance of one of our locations, I'm going to be targeting you. So that's a good example of another type of marketing called pay-per-click that we would deploy. Next slide, please. I mentioned the data we use. What that ultimately comes down to is households are assigned a brand receptivity index. Every prospective patient we potentially target is assigned an index. If you over-index, you see the middle figure there is over-indexed at 260. That means they're 2.5 times as likely to need pain management based on our data as a typical household. That's a great candidate to target. You see the 45 there on the left. That's a household that is what we call brand resistant. Maybe they're young. Maybe they're, the data doesn't suggest that they are. In fact, the data suggests they're less likely to respond to our ads. And then down at the bottom there, you see a couple of examples of ads that we've used in the past. That first one is a a postcard that we would send to a prospective patient. And then the right-hand one is a Facebook ad we would put in front of a prospective patient. Okay, enough theory. Let's go to the next slide and let's actually look at some of the data, campaign data, if you will. So what I'm showing here, the top data, this is actual spend and actual results based on our pay-per-click campaigns this year. Last year, so a year and a half ago when I joined, I didn't come in guns a-blazing saying, give me all kinds of money. I said, give me a little bit of money. Give me and my team just a little bit of money to invest in marketing, and I will prove the effectiveness of it. And so that's what we did. And then as we got to the end of last year, I said, listen, we've proved it. Give me a little bit more, and I'll take it even farther. And so what you'll see here is in January, we were spending $30,000 a month in the month of January. Now, think about it in the terms of the number of locations. Back in January, we had about 80 locations. So it's, you're talking about less than $500 a month per location, across the network. But we invested $30,000. We drove 2,165 leads, and we had 149 new patient consults as a result. Now that's just based on pay-per-click. There are all kinds of other marketing channels we were executing at the time, but that's just pay-per-click, conversion of 6.9%. So of those leads that came in, we converted 149 to NPCs. And we ramped it up a little bit in February, ramped it up a little bit in March. April was a tough month. Of course, COVID hit. There were less people searching online for pain, but nevertheless, we drove 2,400 leads, converted to 157 NPCs. You also see the cost started going up in March, April, and May because they weren't converting as well for the most part. But bottom line is, you look at September and October's data was very similar. At this point, we're driving about 5,000 leads a month. We're driving them into the website. People are scheduling on Doc ASAP, driving them to the call center. People are scheduling appointments over the phone. And we've driven that cost per acquisition down. Well, one, we've driven up NPCs. We're talking about 325 per month now. Again, that's just paid. The number is more like 1,000 if you look at all the leads that come through the website, 1,000 NPCs a month coming through the website. Cost per acquisition on this particular type of campaign in September was $240 on average. It's about $250, and we continue to drive that down. So all in, we're going to come close to 3,000 NPCs driven by pay-per-click this year. And again, people are showing up to your locations. You don't realize it, but they're showing up to your locations because of these campaigns. They don't walk in with a big Google banner saying, "Hey, I clicked an ad on the internet." It's not the way it works, but they're coming, and we're going to continue to ramp this up. The next campaign you'll see down below on the right-hand side, this is the integrated campaign that I was talking about. It's direct mail, and it's digital across platforms. There are 3 different campaigns here. One was from last year. That drove 330 incremental patients, 796, and that middle campaign, Always On 2.0. Always On means it's literally always on. That campaign started in January. It involved direct mail, and then we cut back on the direct mail when COVID happened, and we focused on digital because it was a lot less expensive. Even in the midst of COVID, we generated nearly 800 incremental patients between January and August. This is across 20 plus different locations. And the interesting thing here, we call it Always On, is the reason we do that is digitally, the patients that are targeted, the 130,560 patients that were targeted, they saw us online. Might be when they're on CNN.com or ESPN.com or some other website that they frequent. That on average, they saw our ad every other day for 7 months. Now, it might not register every time they see it, but the key thing about this, as men and women of science that you'll appreciate, is that 796 is incremental. So we targeted 130,000 patients, 130,000 households. We put aside 20 to 30,000 households that looked and acted demographically and psychographically exactly like that 130,000. We call it a control group. In medicine, you call it a placebo. It's the same thing. Essentially, we targeted households that, looked and acted the same, and we held out a control group that looked and acted the same distance from our locations. And so the 796 that you see there and always on 2.0, that simply represents what we call lift over control, the difference in the group that was targeted versus the group that was the placebo, the control group. And likewise, always on 3.0, that's currently in market right now. We've got about 35 locations we're targeting, 176,000 patients. And that's the projection. So that's why I have an asterisk there. That's not actual data, that is projection, but always on 1.0, always on 2.0, that's real data, real incremental households, and you can see the charges add up pretty quickly. Next slide, we're going to transition to talking about, again, I love data. We're going to talk about some of the data we're using to determine what's going on in the marketplace. On the left, one of the analyses we've done is, we're trying to understand how are we performing versus the marketplace, in the age of COVID. And what you see on the left here, these are Google searches related to pain management. So it might be people Googling lower back pain or pain management physician near me, or something of that nature. You can see this is a 3-year trend. It tanked in late March, April, May, and it's come back. It's not quite back to where it was at the beginning of the year, which frankly, as I'm sure most of you have experienced, that's NPCs are in the same spot. They're better than they were 6 months ago, but they're not quite back to where they were earlier in the year. And what we found is analyzing these search terms, there's almost a perfect correlation. It's 0.88 correlation. Our factor is 0.88. Of course, a 1 would be perfect correlation. Anything above 0.7 is a very strong correlation. So we're at 0.88. Basically, people are searching online for help to their pain, and ultimately they find us. Likewise, if you look at the right chart, these are select specialties and the search terms related to them. So chiropractor, neurologist, rheumatologist, very similar pattern. And again, those specialties are not quite back to their pre-COVID levels. So what does this tell us? It tells us, number one, our direct-to-consumer efforts relative to NPCs are going to underperform. There's not as much demand in the marketplace. Maybe because they're afraid to come to the doctor's office. Maybe it's because they're out of a job now, they don't have insurance. And the same applies for all the other specialties. So not only are we getting fewer NPCs from a direct-to-consumer standpoint, we're getting fewer referrals from these other specialties. Next slide, please, as we come home. So these are referral patterns for both NSPC and Prospera. We haven't merged the data together yet, but you may notice pattern, right? Huge drop off in April and May. Things aren't quite back to where they were before. So in addition to our consumer direct efforts that we've proven still work during COVID, particularly, although not quite as well as they did before because of COVID, they're still working. A lot of the messaging has to do with the fact that we're using ways to protect them. In fact, Peter Stotts and I were talking about this just the other day. We've enhanced our messages. We're going to do more to reassure people that we're taking precautions to help them. We've also been promoting telemedicine. It's still at 15 to 20% of all appointments are via telemedicine. But referrals is where we're going to turn our attention next on both sides, on NSPC and Prospera. We cut back staffing on the NSPC side. We furloughed 25 salespeople that are out in the marketplace, engaging with referral sources. We've been engaging those referral sources to some degree digitally, and we've also been engaging some of those referral sources through direct mail and outbound phone calls, only about the top 500. But if you look ahead to 2021, what I do expect us to do is start piloting a new approach to market engagement of referral sources. There'll be fewer liaisons, and they'll be targeting a smaller number of higher impact referral sources. So imagine, say in fact, if the team from New York is on, I was talking to them just the other day about this. We're going to have one person assigned to New York that's targeting these prospective referral sources and current referral sources, but they're not going to be using as much shoe leather. They're going to be engaging them virtually. They're going to be engaging them, if you go to the next slide, via direct mail. So this is actually a kit we developed. One of the things that ultimately what liaisons do is they help us stay top of mind. They help you stay top of mind with these referral sources. And they would typically do that in person. They'd bring a box of donuts, they'd bring lunch, they'd bring referral pads, they'd bring literature to these referral offices. And one, that's hard to do now because a lot of these offices still, depending on the market, still don't want reps in their offices. And two, we're not going to have, as we did in last year, we're not going to have one liaison for every 3 offices. We're going to have one liaison in the pilot, one liaison for each market. But they're still going to be able to reach these referral sources. This is one example of how we delivered referral pads to our top 500 sources. There was a letter from Doug in here. There was a referral pad and so on. So that is the next thing for our approach to referral sources. So again, it's a combination. It's a balance, if you will. Consumer direct. That methodology is working. We're going to reinvent the referral piece, and certainly there'll be more to come on that. With that, I'll turn it back to you, Peter, and thanks for the opportunity to participate.
That's great. So Bill, before we kind of turn it over to Dr. Patel, I want to kind of tie these 2 sessions together. One of the concepts you and I discussed this, I guess it was just at the end of last week, was that the key reason people are not going to see their doctors today, not just in interventional pain management, but medical specialists in general, 88%, I think was the number we discussed, was because there's a concern of cleanliness, or that they may get sick at their doctor's office and they don't know what they're doing together. So, today with COVID being so prevalent and, it's spiking everywhere across the country today. And look, there's good news that Dr. Patel is going to tell us about, but we need to take what Dr. Patel is going to tell us now about how we take this so seriously and take the safety for our patients seriously and explain it to them. Now, some people, I think, get the idea that marketing is a bad word, that if you have to go out and market that, but really what marketing is, it's information. It's trying to get two-way information, get information to our patients and our consumers that here we are, we're quality, and then get information back so we can act accordingly. So as you guys think of things, as I did this past week, call Bill and say, hey, Bill, I got an idea for my practice. And I don't know, Bill, if you want to talk about how you want to work with everybody very briefly, that'd be great.
You make a really important point. In some ways, what marketing ends up being in the world of NSPC is patient education, right? And to your exact point, if you haven't done this, many of you have, dozens of you have, but if and we haven't implemented the technology for Prospera physicians yet, but we're about to in 2021. We have a system that historically has been used to communicate patients about their upcoming appointments. Interestingly, NSPC's no-show rate is much lower than the no-show rate on the Prospera side, in part because we have a platform that sends an email, sends a text, and sends a voicemail to every patient leading up to their appointment. And during the crisis, we realized that this was a really important communication tool to do exactly what you just said, to help to reassure patients and help them realize we're taking precautions. We've got telemedicine. And so thanks to Dr. Robert Wagner, it was his idea. And to your point, we're open. If you've got a great idea, share it with us. Send it to, it's simple. Send it to marketing@treatingpain.com. It goes to my entire team. What Dr. Wagner suggests is, why don't we have our physicians record a voicemail and send it to their patients? So, this is Dr. Robert Wagner. I'm calling to let you know that our centers are open and we're taking precautions to protect you during your visit. We are also offering telemedicine. It's a simple message. We've had liftover control. So we held out a control group and we targeted past patients with this message, 8% response rate. The average physician had 80 to 100 incremental visits as a result of that voicemail. In fact, I've heard specifically physicians say, you know what? I thought you were crazy. I thought that would never work. And I had a patient in my office today that said, when I heard your voice, I knew I had to reach out and I didn't want to suffer in pain anymore. I'm telling you, if nothing else from this call, we need your help educating these patients. To Peter's point, that we're taking precautions. We've got telemedicine. Don't suffer at home. Reach out to us. Send me an email. We'll get you the script to record, and we'll get you get those voicemails out to your patients. Thanks for that entree, Peter, because it's a really important message our patients need to hear during this crisis.
And Peter, if I could just interject one quick thing about Bill's comment about educating patients. Just on the side, I've worked a lot with our medical writer, Catalina Apostle, who actually is a physician, amazingly. And she's responsible for content on our website that goes all out to social media. So there is unlimited opportunity for you to discuss what you're doing specifically in your clinic. If you're interested in peripheral stim like Dr. Lee, or if you're doing mild, or if you're doing Vertiflex, or whatever procedure you're interested in, trust me, the public wants to know about it. And contact Bill, contact anybody in the marketing department, and they'd be happy to actually write it for you, and you can edit it. So it'd be very little amount of sort of actual writing for you, and it'll go out to all social media. It can be directed specifically to your office or just to the public. And I think that it'd be very much appreciated. As much clinical content that you can add, there's no limit to what you can bring to the website.
Exactly right.
Thanks, Bill.
My pleasure.
So,
Thank you.
It's really thrilled for a number of reasons to introduce Dr. Patel here. I think Dr. Patel will tell you that this is a cautionary tale for two reasons. First of all, of course, COVID and everything that's going on with COVID and the dangers that we need to be careful about. But the second is, as you recall, at the last webinar that we did, I said, anybody who has an idea, call me and talk to me about it. And so Dr. Patel, of course, did. And he said, I think we should do something on coronavirus 19, COVID-19, and we should do an update for everybody. And I said, wonderful idea, Dr. Patel, you're up. And he enthusiastically agreed. And he's going to give us an update of where we are, because it is such a rapidly evolving space right now. So Dr. Patel, please, the floor is yours.
Awesome. Thanks, Peter. I really appreciate it. So these are my disclosures on the screen. Next slide, please. So just a general outline. We're not going to recap everything that we know about coronavirus and COVID-19, but as many of you are aware, there are a lot of exciting things that came out in the news over the past week. And this ended up being very timely with respect to that. But also, we're going to talk about some precautions that we want to take during winter, because there may be a lot of confusion out there with respect to some protocols, and also share some of the updates within the NSPC internal policy. So let's get started. Next slide, please. So I will share a lot of information here, but the most up-to-date information will be available on the CDC websites. And where applicable, I've gone ahead and taken some of the references and put them in the right-hand corner of the slide. And of course, every federal and state entity will also have their own protocols. As we know, there have been a lot of escalating cases recently with the coronavirus, and there's probably many reasons for that. There was the initial loosening of the shelter-in-place mandates in certain states, although we realize that currently a lot of states are reverting back to that. Progressive laxity towards guidelines, return to school is a big one, and perhaps increased testing did affect that a little bit. But as we know that these cases are currently escalating, so we have to be prepared. Next slide, please. And really the gold standard to protect yourself is still to continue to wear a mask and stay at least 6 feet away from others who don't live with you. And the other one we don't always bring up is wash your hands with soap and water for 20 seconds or use hand sanitizer with alcohol. But I thought that this is something that, although we all know, it's nice to hear it again. Next slide, please. So the vaccine, most of you have been aware that we have had ongoing vaccinations that just started really this week in the United States. But just to catch you up to speed a little bit, because this is a topic that a lot of individuals have a lot of questions about because of how quickly had this happen. So we know that when this started, about 30 biotech and pharmaceutical companies rushed to develop a vaccine. And the question was always, how do we balance safety with speed? So we had Operation Warp Speed, which many of you are aware of. And really the government decided to work with a few different corporations, Pfizer, AstraZeneca, Merck, Johnson & Johnson, and Moderna. And as you see here, the Pfizer and Moderna products are what I'll talk about the most because those are the ones that are most available currently in the United States. And these are mRNA vaccines. The AstraZeneca product is DNA. Now, if we note that when it came to delivery of these vaccines, as part of this Operation Warp Speed, they actually told the pharmaceutical companies that you can start delivery of the products, or at least start making the products sort of in the middle of phase 3. But a lot of pharmaceutical companies pledged to undergo all 3 phases of trialing before submitting for the emergency use authorization, even though they were given the leniency to sort of start before that. And a lot of questions that come up are, well, how the heck did we get to this point so quickly? And it turns out when you throw a lot of money at a problem, it speeds things up very quickly. And so these products that are coming out have actually gone through all 3 phases of clinical trials in approximately 6 months, roughly. So we can see that a lot of the data that was collected, and I'll share one of the articles that came out in the last week. And as we know, on December 11th, the FDA issued an emergency use authorization for the Pfizer-BioNTech vaccine. And I'm not sure if it has for the Moderna one yet. And just to clarify, emergency use authorization is not full approval. And what's missing here is really sort of third-party validation of some of the testing that was performed by Pfizer and some of these other biotech companies. So it's a lower bar, but not necessarily a lower standard of safety or efficacy. I think that's important to know. Next slide, please. So mRNA vaccine. So this is actually kind of interesting because we're not typically used to these type of vaccines. Although the technology has been around, it's not really been utilized in a widespread manner in vaccinations. So just to give you a little bit of a background, so the mRNA is wrapped in a lipid nanoparticle, and these specific vaccines are targeting the S protein or the spike protein on the novel coronavirus. And how does it work? Well, once the mRNA enters the cytoplasm, it's converted by ribosomes into proteins. And those proteins are expressed in the cell membranes, MHC2 and MHC1. And not to go too much into the immunology, but essentially those proteins and these receptors interact with T helper cells, which activate cytokines. And that causes B cells to differentiate into plasma cells, and those develop your antibodies, right? So that's sort of the process of how it works. So it's easier and safer to produce compared to traditional vaccines. There's no need for the weakened virus. So these mRNA vaccines have no virus in them. And they're synthetically produced, so there's really no contamination. And because of the fact that they are mRNA, there's low risk of integrating to the host genome. I wasn't really aware that this was a possibility, but apparently that's a theoretical risk of DNA vaccines. And currently the ones that are available in the United States are mRNA vaccines. The nice thing is that they are easier to scale because of the low production cost, because you're not having to use a weakened virus that you have to incubate in eggs. And with the ongoing mutations that can occur with viruses, it's actually easier to adjust the RNA sequences, which is great. Now, of course, there are going to be some inherent limitations with this technology. And one is that the immune system could destroy the vaccine prior to delivery to the cells. And the second one, which many of you have probably heard of, is that there's the need for uninterrupted refrigeration. Now, there's a little bit of difference between the Moderna and Pfizer products. The Moderna product is a little bit easier to keep. Pfizer products need to be kept in quite cold temperatures, frozen during transportation, and that does introduce some logistics that need to be taken into consideration. So it's not perfect by all means. Next slide, please. So I'm going to talk just briefly about the New England Journal article that was published on December 10th. So that was literally 5 days ago. And this was about the Pfizer product. in looking at safety and efficacy, because I know a lot of folks were questioning, with the rapidity of delivery of these products, is this something that was able to be safely done? And if you look at it, the primary endpoints were efficacy of the vaccine as well as safety. And so they had 43,548 participants in randomizations. And I believe that the Moderna product had a little over 30 to 35,000. Most of them received injections, some with the vaccine and some with placebo. And many of you are aware, but some of you may not be, the Pfizer product needs to be delivered in 2 vaccinations approximately 3 weeks apart, while the Moderna was studied approximately 4 weeks apart. Now that's not an exact science, but that's how they were studied. And what we found is that the vaccine conferred a 95% protection against COVID-19 in persons 16 years or older. And if you actually look into some of the data a little more closely, the severity of symptoms was also improved as well. And over the few months that they studied, they found that the safety was similar to other viral vaccines. Now, clearly, this was funded by Pfizer and BioNTech. There's a clinical trial number if you want to look into it a little bit more closely. So you need to take that into consideration, but so far, the data looks very promising. Next slide, please. Now, with the vaccinations, there are definitely some ongoing questions with this. What is really the long-term efficacy? How long will these antibodies last? Will people have to be revaccinated again in the future? And obviously, what's a long-term ongoing safety? But as I mentioned, with the technology, there is some inherent safety when compared to traditional vaccinations. And again, with a lot of the money that's being funded into this project, I do believe that we'll have a lot of that data hopefully in the near future as I continue to monitor this. Next slide, please. All right, so winter. As we know that a lot of the symptoms for COVID-19 overlap with other viral illnesses that are occurring during this time of the year. So I thought it'd be nice to sort of recap a practical approach that we can take during this winter season so that we can understand when it's appropriate to quarantine and when it's okay for us to continue what we do. Fever, cough, headaches, fatigue, muscle aches, those are all very similar symptoms to a lot of different illnesses. So what do you do if you're sick? Well, let's look at a couple of scenarios. If you have contact with someone confirmed COVID-19, you're going to clearly undergo testing and don't come into work until notified. And we're going to go over a couple of the NSPC protocols in the next few slides, but just make sure you notify the appropriate parties. Now, if you have a fever, if you're at home, stay home and undergo testing and don't come in until you're notified to do so. And then if you're at work, you can go home and then make sure you undergo testing and then follow the NSPC protocols there. Now, if you have no fever and have not had any confirmed contact with someone with COVID-19, you want to watch out for sort of pathognomonic symptoms. So if you're having loss of taste or smell, at the moment, that's probably COVID-19 until proven otherwise. So you want to treat it as such. But if you don't really have any of these other symptoms, then make sure you notify the appropriate parties. And if you're at low risk for COVID-19 exposure, continue to come into work and ensure vigilance with respect to wearing PPE as well as other sterile procedures. And of course, if your symptoms change, you're going to want to change your risk stratifications. But this is sort of a simple way for us to be able to determine what steps to take in the initial phases. Next slide, please. So I'm going to share the reduced quarantine option that the CDC has proposed. Now, a couple of caveats. Number one is this has not been accepted by a lot of local and state authorities yet. And the CDC has allowed local and state authorities to sort of establish their options for their jurisdictions. Number two is these are not necessarily set in stone, and they're going to continue to morph and evolve as we understand more about the virus. But there's a proposal that quarantine can actually end after day 10 instead of after 14 days without testing if no symptoms have been reported during monitoring. With this strategy, the risk of post-quarantine transmission is about 1% with an upper limit of about 10%. Now, when diagnostic testing is sufficient and available, the quarantine can end after day 7 if there are no symptoms reported during monitoring and if they've had testing within 48 hours of the planned quarantine discontinuation. And this has to be PCR testing, not just antigen or antibody testing. And the risk of post-quarantine transmission risk is about 5% to 12%. So not great numbers, but these are different options that individuals are looking at. In either situation, you still need to continue symptom monitoring and masking through day 14, even if you're able to come back earlier. Next slide, please. So last few slides, let's go over the NSPC COVID-19 policy update. So number one, again, this is not set in stone. This is a very fluid process, and we'll try to give you guys updates as they come. And number two, this may not apply to every single person. Everyone's individual immune state, everyone's individual situation will need to be handled case by case. But this is just to give you a general guidelines to go off of. Even though there's mostly clinicians on the line, I think it's important for you to know both from the staff perspective as well as a clinician perspective what to do. So if someone in the office tests positive for COVID-19, if everyone in the office was wearing PPE and social distancing was followed to, then there's no need for the remaining staff to be quarantined as long as they remain asymptomatic. Staff may get a COVID test if they suspect that they have contracted the virus. Any staff member awaiting the results of COVID testing should remain in quarantine until the results are provided. Any staff member who tests positive for COVID, whether or not they are experiencing symptoms, must follow certain guidelines, which I'll go over. And of course, you want to clean the area where the sick person had worked and use appropriate PPE during that time. Next slide, please. If a physician or mid-level tests positive for COVID, then they must follow certain guidelines for return to work, which again, I'll go over. In order to be considered infectious to patients, you must have been in contact with the patient as few as 6 feet apart and for more than 15 minutes in the 24-hour period, at which time, if they have been determined to be in close contact with any patients, then those patients should be notified and contacted once the provider tests positive. So just something to keep in mind. Obviously, you're not making the calls yourself, but these are different protocols that we will be following. Next slide, please. So returning to work. So if you're a staff provider or otherwise, there's a couple of approaches that we can take. If we're using a system-based approach, you may return to work if all the following are true. If there have been at least 10 days since symptoms have first appeared, and at least 24 hours have passed since the last fever without the use of fever-reducing medications. And if all of your symptoms have improved, you may return to work. Now, of course, local and state guidelines may supersede this, and always check with your treating provider because everyone's situation will be a little bit different. Next slide, please. If we have testing that's available, if you have resolution of a fever without the use of fever-reducing medications, and if you have improvement in your symptoms, and the results are negative from 2 consecutive PCR tests within 24 hours apart, then you may return within 7 days. And staff and providers who are asymptomatic throughout their infection, again, need to have at least 2 tests using PCR methods. Antigen and antibody testing is not sufficient. Next slide, please. So if you're caring for a family member who tested positive for COVID-19, it's a little bit different. Anyone who's cared for a family member with known or suspected COVID-19 should quarantine for 14 days following the last exposure to the sick individual, or 14 days following improvement in symptoms of the sick individual. So if for any reason you're caring for perhaps a child and they do contract COVID, then you must count 14 days after the last time that they showed any symptoms before you can return to work. And anyone who's had close contact with someone with COVID-19 who meets all the following criteria does not need to stay home. And obviously, if you've had a confirmed COVID illness within the last 3 months, if you've fully recovered, and if you remain without any current COVID symptoms, then you may not necessarily have to follow these guidelines. Next slide, please. Couple of things, maintain vigilance. You know, we're all tired of this, we're all burnt out, we're fatigued, but really stay focused. The next few months are probably going to be the most important, especially with, again, the sort of dynamic changes with our social structure, the rollout of the vaccine, but continue to remain vigilant. At work, wear your mask and gloves at all time. Keep them on even when you're at your desk. Continue to follow in-office protocols and continue to perform temperature checks on all staff members and patients. Now is not the time to sort of let up on this. Outside of work, limit unnecessary travel outside of the home. Again, the holiday season is coming up. Just be smart about it. You're a vital employee. Try not to take unnecessary risks. If you're going to travel, wear a mask, limit contact with other individuals, and remember to socially distance. It does work. Last thing, just to kind of recap as we're finishing up this talk is, with the vaccine, I think it's going to be important for us to try to do our best to control any misinformation that's out there. Obviously, a lot of dynamic information is out there. And so, try to educate yourself as much as you can. I think most individuals are finding that this is something that's going to be very beneficial for all of us. And again, I have done a little bit of work on this. So if you do have any questions, feel free to reach out to me. One other thing that came up that I forgot to mention is some people have asked whether or not they should get vaccinated if they've already had coronavirus. And what we've actually found is that certain viral vaccines do not induce enough antibody production in order to protect yourself for for ongoing COVID-19. And that's why some people actually have gotten it more than once. And so even if you're someone who has had COVID-19, it would still be appropriate for you to get vaccination, assuming you have no other contraindication. So that was my only other thought. But thanks so much, Peter. I appreciate it.
Hey, thank you very much. So you've left me with a couple of unanswered questions, and more than a few, I would suppose. But
Yeah.
One of the areas that I think has been really kind of very interesting is once you've had the vaccine, can you still be a vector for transmitting the virus?
So the answer is that they don't know that yet. Once you've had the vaccine, you would think that you can, but what they do know, and the only thing that they've really studied, is that your own symptoms and your risk of getting it is low, but they don't know yet if you can be an asymptomatic carrier and still transmit the virus. So there are ongoing studies still with relationship to that.
Yeah. One of the key things we've spent a lot of time as a community talking about the risk of getting the virus, risk of hospitalization, and the risk of death. We've spent very little time on the topic of what has been termed long haulers, or what the long haulers like to be called is post-acute COVID syndrome. They don't like to call it post-COVID because they feel like they have it.
Yeah.
And I think it's important to note that up to a third, maybe 20 to 30%, various studies have said different things, of patients who get the virus are going to develop some kind of long hauler symptoms. So again, as I said on our first webinar back in March, probably, don't get sick. And then I guess I'll end with, the big question is, so this is an mRNA virus. So there's really no chance of this getting intercalated into my DNA. So I can't get spidey sense skills out of this.
Unfortunately not, but I'm sure someone out there is going to get something. So they'll post it on YouTube or do something about it.
Yeah.
One other thing I want to mention is when I looked at the data from Moderna and Pfizer, I alluded to this before, was when it talks about severe symptoms, no one in the Moderna group who received a vaccine ended up with severe enough symptoms that required ICU admission compared to the placebo group. And I think with the Pfizer product, one person did. So that's pretty huge numbers when we look at the overall data.
Yeah, that's great. Ketan, thank you very much. And everybody listen carefully to Dr. Patel for that word of caution. At the very end tonight, I'm going to ask you all to come up with a new idea and a new topic that you want to cover. And just like Dr. Patel did, I look forward to working with anybody out there who wants to bite something off. So thank you again for an excellent, excellent presentation. So with that, I'm going to turn it over to my good friend, Dr. Gordon. Dr. Gordon is Director of Outcomes Research, and I gave him this difficult title of the value proposition, but Dr. Gordon spends a lot of his time thinking about our overall outcomes, what questions to ask, what's important to our payers, what's important to our patients, what's important to regulators, what's important to us, on the therapeutic therapies that we offer. So I've asked Dr. Gordon to talk about a global perspective of how we're addressing the problem at NSPC. So, Dr. Gordon.
Hey, thanks, Peter. And I appreciate you putting on the tie and jacket for this formal talk. And thank you. Next slide, no disclosures. So I think I would just start with just giving a brief update about the CMS final rule that came out about a week and a half ago. And most people, when they think about outcomes and quality, the first thought that comes to mind is not federal reporting, but because there is a lack of really understanding of pain management, what pain management does, really this is how you're graded with regards to if you're a good or a bad physician is still the CMS or the Medicare MIPS program. And so I know that Peter didn't have much chit chat, but if there were backpacks to be given out, I think the question is, what does MIPS stand for? And the reason that many of you may not even know what that means is that I think the goal of joining a big group like NSPC and Prospera is that a lot of these processes are taken care of for us by people on the back end or the staff so that we can worry about treating patients. And so MIPS does stand for Merit-Based Incentive Payment System. And just a little bit of a heads up is that your score and how you're doing throughout the year is likely to be on the app by about Q2. So we're working on that. And so I think that'll be a easy way for everybody to see how they're doing. And I think many of us look at our data for our office and how we're doing compared to our peers. And the same will be for the quality program and the federal reporting. So you'll be able to see what your score is and see what you need to do to get better points. So every year, really three things, sorry, if you, actually you could stay on this slide. So every year, three things happen to really set up the next year, right? One is that the AMA changes codes, they add codes, they may take out codes. The other is that CMS or Medicare can add their own codes or make changes to codes. And something else that happens, which of course really pertains to us, is they determine how much they're going to pay for things. And so when the final rule comes out, obviously David and the CEO and the financial team will look carefully, and I'm sure you're going to get some information of how pain management did this year compared to prior years. Every year is different. It might be a good year for urine, it might be a bad year. And so I think that information is about to come out. The overall sense I got was that there isn't any big changes for pain, which is good. Some years are better, some years are worse. And so just a little bit of an update for this year on the MIPS program. Again, the federal reporting is basically, kind of with COVID and everything, it's like, is that thing still around? It's like, yep, it's still here. And it's actually started a few years ago, if you remember, for meaningful use. It's been also called meaningless use because it doesn't really help patients. Not really. There's a lot of busy work. Yes. Will it maybe get better? Maybe. But we're still stuck in a lot of busy work that at this point is not really helpful to patients. But what you can see is where Medicare is going, and also a lot of the private carriers will follow Medicare. And so just some things, they're making the performance thresholds a little higher, so that you have to hit 60 points, which is harder than in prior years. And we're starting to get into the real penalty phases where if you don't meet these criteria, you'll have a 9% penalty. It was, if you remember from prior years, it was like 2% and 4%. We're getting into now the maximum, which is 9%. And so the idea is that the reason to check your app in the future about the score is that if your score is lower and that doesn't reach certain criteria, is, you'll get paid $100. Your buddy may get $100 for an epidural, but you may get 91. So some people say, it's not worth my time, but it certainly would be nice as an organization to all get a maximum payment for what we're doing. And obviously we have staff and folks working on this. So mostly you don't have to worry about it. So there's 4 components to MIPS. One is basically the computer aspect. They're promoting interoperability. The other is improvement. Those are the 2 kind of gimmies. We're going to meet those, and we haven't had any issues in prior years meeting those. The other 2 is cost and quality. So cost this next year is going up to 20% of our score, and quality is 40%. The following year, it's gonna eventually be 30-30. So we're going to be even in terms of, we're going to be rated on how much cost it costs us for us to do care, and then how good of doctors we are in the future. And so with regards to cost, I just want to take a moment and just have you understand that the number one thing that you as a pain doctor can do about your cost is not reduce the number of epidurals or think about, hey, I don't want to do stim because of cost. That's actually not the way that that you can help your cost as it's attributed to you. The number one thing is to make sure that your patient has a primary care doctor. And that may sound a little strange, but right now, the cost of someone's care, if they don't have a primary care doctor, goes to those physicians who are most active in their care. Many of our patients we're seeing every month, sometimes more. And so if some patient has a CHF exacerbation, pneumonia, they're going to the hospital, strangely enough, they think that we're the primary care and that cost goes to us. And so we do have sheets on why it's important to see your primary care. Just if you're wondering why we're going to be promoting this, just know that this is to try to make sure that those costs of the patient's overall care are attributed not to us, but to the primary care physician, and we're not really responsible for the patient's CHF exacerbation. Quality, just a little news about quality is that unfortunately, there are three measures that we've been using for the last 5-6 years that really help us out. Things like documentation of assigned opioid treatment agreement, evaluation or interview for risk of opioid misuse, like giving out an ORT. These are really fundamental to what we're doing, and we report on these, and it hasn't been an issue. This next year, unfortunately, the American College of Neurology, I don't know if there's any neurologists in the group, but they really screwed us because they said they're not going to support these measures anymore for some unknown reason, and that and CMS had no choice but to pool them. So next slide, please. So unfortunately, because we're missing out on those 3, we got to go back to some of the ones we had before we started using those 3, and things like tobacco, things like body mass index, things like even pneumococcal vaccine may be things that we're looking at carefully over this next year. So next slide. In terms of, this is a modernizing medicine slide shows that if you wonder why your staff are going to be asking about vaccination status this next year, and you're like, that has nothing to do with my quality as a pain physician, at least at this point, that's what we're unfortunately having to do. But I'm hopeful that we can try to make some headway. We're even in discussion, perhaps we could form our own quality data registry. We're just really going to do our best to make it make sense for us as pain doctors. And so our staff doesn't have to do things like pneumococcal vaccine, which is obviously a waste of our time. Next slide. All right, so now to more standard discussion of outcomes. And another way to talk about outcomes is really telling our story. We work on the front lines every day, seeing patients who are challenging and going through a lot of different issues. And it's very hard for even our own private equity partners or our payers or even the community to understand what we do. When you ask a lot of primary cares, they think we just dole out opioids. They may not know all about our other sophisticated treatments. And so I see outcomes as really, rather than formal research under Dr. Vallejo in terms of randomization and control groups, we're really trying to tell our story through data. And so I think a big message is that we're going to be calling on you as the physicians and providers in the offices to really help us to get information from your patients. And so we will be administering surveys regarding our various services. And there may be some surveys on paper, some surveys on email, some surveys on tablets in the office. But it really helps to have the buy-in because, hey, if you're doing a cool new procedure, or if you're just giving opioids or doing radiofrequency, these are procedures and services that help people, and we want to share that with the various audiences, as Peter mentioned, the carriers, our own stockholders, also our patients. And this is just vital information that we want to communicate. In terms of the platforms, we'll go into that, but the surveys will go into response to interventions, as well as especially the higher acuity procedures like pumps and stims and zip and implants and the peripheral nerve stimulators, because these tend to be more costly to the carrier, and we want to demonstrate our value and superiority to perhaps surgeons in what we're doing. Another key piece is looking at opioids, because opioids obviously is on the minds of every carrier and our sponsors in the private equity world, because we want to demonstrate that we're being responsible. Next slide. So this is just an example of a paper survey. It's old-fashioned. It may not be fancy, but as we're gearing up our other platforms, this is a simple thing that we can actually, I've just done some of the work with legal, and we're just got to go ahead. And so this is something that you can easily administer in your office and send on to me, where patients are going to be asked, this case, really 2 questions. There's a few components within it, but the idea is very short, simple surveys to begin with. We can walk and then run. But how did this is an example of a mild treatment, but various treatments. How is this helping you? And next slide. And so you get results like this. This is an example of our anesthesia services. Some of you have started to use anesthesia in your offices. And you see just the overwhelming success in terms of patients reporting that they believe this is a valuable service. And so those are the types of things that it's not going in the New England Journal, but I think it's going to be very effective for giving our message that we're really taking the best care of our patients. Next slide. With regards to opioids, this is an example of what we're shooting towards, is that we try to have, we're going to try to have folks understand where they are in terms of comparison to their peers in their organizations. So this is within Virginia, we get a report saying these are our standard opioid MMEs, the duration that the patient's on the opioid. And this will be helpful, I think, to understand what your opioid prescribing patterns are and where they fit. And it'd be important to understand, especially if there are outliers either way, if you're very low and how many opioids you write, or if you're very high in certain respects, it'd be important to just understand that as you move forward. And next slide. So we looked at some aspects within the Virginia division, and this is just a demonstration over the years of how we have increased the number of low MME agents over the last 5 years. And next slide. And conversely, this is a very nice slide, I think, for our carriers and for our private equity partners. And as the low MME agents went up, we have clearly reduced the high MME agents. And if you look at things like oxycodone 30 milligrams or fentanyl 100, especially when the CDC guidelines came out, it's just been a straight reduction. And that's been very interesting to gather the data from the EMR. Next slide. So with modernizing medicine, we can look at the various opioids that are prescribed. Next slide. In various ways, and further comparison between divisions. And next slide. And we can also look at outliers in terms of the amount of prescriptions written by for certain agents. And I think it'll just be important for as an organization and for you as an individual provider to understand where you are. And that is the information that's likely to be formed on an opioid dashboard. And next slide. So I think in terms of our outcomes, the key is that we need the information from our patients to really tell our story. And I think that over the next several months, we're going to solidify the technology-based platforms from which we get that information. So you saw an example of a paper survey. I think while we're getting that information totally solidified, we will be administering the paper surveys. We'd like to have all of the information that we need in terms of depression, sleep, mood scales, all those things come in through our EMR, but sometimes the EMR and the portal with the EMR is not as good as a third-party app. Obviously, listen, we want to have everything by text or on a mobile device. That's where patients live. That's where we all live. And so we want to be able to do that, and we're working on platforms for that. Interestingly, that especially Peter has been very interested in remote monitoring, and I think this, especially with the Medtronic, the potential for looking at different ways to measure movement and function can be something that can be done. We're also looking at EMR-based surveys within Modernizing Medicine, so it's all contained within that. And I think there's also a role with private payers that they can share their data with us. For example, with Care First, we're looking at ways to improve our payments through following certain measures, like the use of opioids and high dose. They're going to share that with us, and if we improve through their data, then they're going to give us incentive to mark that. So I think overall, we have a lot of ways in which we can tell our story to our various audiences, and I think that's going to be very valuable over the course of the coming years.
Thanks, Asaf. Again, a wonderful presentation that kind of takes us from MIPS through how we're looking at the problem. And you know, there was so much data and depth in what you talked about. I think a couple of things just should be re-emphasized. One, we will be able to have the data on anybody's prescribing patterns, for example. And so with that, it's not that anybody's out of line or doesn't prescribe enough or prescribes too much, but I think it's important that each and every one of us know what we're prescribing compared to everybody else. So we don't kind of get a note from the regulators from the state of Virginia that says, I prescribe 10 times what everybody else practices. If you know the information up front and going into this, you can explain it, you can document better, you can do various things, or you may make the decision that, hey, maybe I am prescribing a little too much. So I think that's an important aspect of quality improvement over time for us to actually know what everybody's doing, as opposed to get that funny letter, which we've had a couple of times in the past that says, this person is out of compliance with the state of blah, blah, blah's program. The other thing is, I think many of us are really high on the interventions that we offer. And on a previous lecture, Vip talked about how with an implanted device, we could take so many pills off the street. And I think we believe in what we do. There is a halo effect around what we do. But at this point, you know, Asaf will be able to say, okay, everybody who does a peripheral nerve stimulator, here's their starting opioid and here's their ending opioid. Did we make a difference on that metric alone? So I think there's a lot of really cool things that we're going to be able to get out of that. So
Agreed.
Yeah. Asaf, thank you very much. And it's also with great pleasure, we turn it over to Dr. Lee. Many of you have met him in the past. He's given one of the other lectures in the past. But I think this is one of the areas that I think is really interesting that was not around, literally wasn't around 10 years ago, because we needed to perfect our ultrasound skills. We needed to perfect the equipment we use to implant. We needed a better science of how we're actually thinking about peripheral nerve stimulation. And we needed a regulatory pathway that you could get paid for this. And those four areas have really come together and coalesced into a new field of interventional pain right now, where I think it's peripheral nerve stimulation. And I asked Sean to give us a review of where we are in this field, uh, um, really burgeoning and taking off, taking us to the next generation. And, you know, frankly, I think everybody should have some familiarity with everything that Sean's about to cover. So with that, I'm going to turn it to you, Sean.
Thank you, Peter. It's always great seeing you, and I couldn't have gotten a better introduction. You've put together an amazing panel this evening, very practical from key marketing tools from Bill, practical COVID-19 advice from Ketan, and definitely Asaf with the value-based introduction of MIPS. And I think someone asked me today, a family member, a son asked me whether or not I was anti-opioid. And I said, no, I'm pro-opioid safety. And that's what we're trying to do here in our corporation. So today I'm going to talk a little bit about peripheral nerve stimulation. While my disclosures are on the screen there, I think if any of us who do neuromodulation in the last 5 years, probably with the advent or introduction of high frequency, I would consider that as a renaissance of spinal cord stimulation. But really for peripheral nerve stimulation, then it was in its infancy, especially when I was in fellowship. But right now, I think we're going through the renaissance of peripheral nerve stimulation. There's so many exciting things going on, and I hope I can share some of that with you this evening. Next slide, please. So we're going to talk a little bit about how we got here from where we were. We're going to talk about some of the applications of peripheral nerve stimulation, current literature and studies, some of the advantages and disadvantages and challenges that we face utilizing peripheral nerve stimulation, and some emerging trends. First off, just the added value, some of the things that Dr. Gordon talked about in terms of bringing value to our patients. It comes at a much lower price point than an implantable spinal cord stimulator, and sometimes offers similar, if not superior, results. So I would just want to share some of these things with you today, and hopefully you can incorporate that in your practice as well. Next slide. So we all know that peripheral nerve stimulation is a form of neuromodulation. It's a therapeutic way of modulating the peripheral nervous system, and it's done through an electrical field. It could be directly targeted to a named nerve, or it could be targeted in a field where that peripheral nerve may exist. Next. And without having to spend too much time on opioids, I think in the right place and time, opioids are definitely, applicable, and even today. But I think the paradigm has slightly shifted, and with the new CDC guidelines, we're just having to incorporate other treatment options, and definitely interventions is where we lie. And I think peripheral nerve stimulation is something that all of us can incorporate easily, especially when you said earlier, the culmination of improved technology, improved equipment, and improved ultrasound skills and miniaturization of devices. So next. Just to remind everyone, in terms of the new CDC guidelines, this is a part of the checklist. Whenever considering long-term opioid management, you want to make sure that you've maximized all of the interventions and non-opioid options. And we'll kind of move past this one quickly and get to the crux of the talk tonight. Next. So peripheral nerve stimulation has been around forever. This is an ancient depiction of auricular acupuncture in the Han Dynasty. This is then followed by this Persian surgical text utilizing cauterization of the ear to treat migraines. And then we've evolved further on into modern day, so contemporary peripheral nerve stimulation. Next. it actually predates spinal cord stimulation. With the introduction of the gate theory by Wall and Malzak, Wall also worked on the introduction of stimulating a peripheral nerve with Dr. Sweet. And it was actually implanted prior to the use of spinal cord stimulation. And I just wanted to outline and point your attention to the frequency there. So high frequency is not new either. But the approval from the FDA for the use of peripheral nerve stimulation is quite recent. And that is to say that we're still in its infancy. Next slide. And this is a sort of a timeline of events in terms of how we got here. And if you look at the most contemporary events, for example, the study done by Deere that was published, you'll see in a few more slides, we're truly sitting on the shoulders of giants. And a lot of these giants sit within our NSPC corporation. Dr. Stats, Dr. Vallejo, Dr. Benjamin were all principal investigators on that study, and probably helped inspire my interest in spinal cord stimulation and peripheral nerve stimulation and carrying out clinical research. And the next two studies, I'm really proud to say that I've been collaborating with my partners here. Dr. Mack and Dr. Patel have all served as investigators on these studies. Next. So, role of peripheral nerve stimulation, obviously we're dealing with a chronic refractory neuropathic pain condition. Anything that has a distribution or an involvement of a peripheral nerve, especially when spinal cord stimulation is not available or not applicable, and it comes at a much less cost. Anytime the patient may respond to a peripheral nerve or peripheral nerve anesthetic block, you may want to consider this treatment option. However, the lack of response to a block or TENS therapy doesn't necessarily negate the efficacy for peripheral nerve stimulation. In terms of neuropsychologic clearance and a successful trial, these concepts are changing, especially when trials can be actually permanent implants, can be definitive therapy, as I'll talk about the 60-day peripheral nerve stimulator implants and devices. Next, please. So a little bit about this basic science of peripheral nerve stimulation. It all goes back to the gate theory. However, there's some nuances. We know that there's orthodromic stimulation of sensory alpha 8 beta fibers, essentially distracting or causing physiologic changes in the periphery. You're modulating interneurons within the dorsal horn. So just because the stimulation happens in the periphery, it doesn't mean there isn't any physiologic changes in terms of how the spinal cord is behaving. And that can come into play when we're dealing with chronic pain conditions such as complex regional pain syndrome involving neuroplasticity. We're also causing changes in modulating the local neurotransmitters and changing the inflammatory state in terms of mediators in the periphery. And we're reducing some of these ectopic discharges, and sometimes can be shown to change the way our peripheral nerve degeneration is behaving. So it can decrease the rate of degeneration when there's injury. Next slide. So far, indications, a couple well-known ones, post-herpetic neuralgia, post-surgical neuralgias, migraine headaches in forms of various internal and external devices, occipital neuralgias, various complex pain conditions such as CRPS, and some of the other lesser known chronic pain conditions like coccydynia, some focal pain conditions, and diffuse pain conditions like fibromyalgia. Next, please. So challenges. So up until recently, peripheral nerve stimulation has been definitely riddled with hardware limitations. Much of what we used were utilized or indirectly pulled over from the world of spinal cord stimulation. Essentially, we were using hardware and equipment that were not designed for that purpose. Most of us have done peripheral nerve stimulation, especially like occipital nerve stimulation using spinal cord stimulator leads, which often can migrate and erode through the skin. in the past, there was challenging reimbursement challenges in terms of authorizations, limitations, and poor reimbursement prevented us from utilizing PNS as a form of pain relief. They also have limitations in MRI conditionality. We talked about lead migration and fractures. That was seen often in occipital nerve stimulation applications. Hardware failure, that was mainly due to the fact that we just didn't have dedicated hardware designed for peripheral nerve applications. I think the infections and hematomas and so forth, they're more applicable to SCS implantations. However, these new innovations in peripheral nerve stimulation have drastically reduced because of their inherent design and some of the innovations that I'm going to talk about in a little bit. IPG design, they've miniaturized, they've become micro stimulators, where I consider them ultra minimally invasive with indirect external power cells. New slide. So here are some innovations. We have now dedicated peripheral nerve stimulation hardware. There's several available on the market now. They're both percutaneous. You can use them under ultrasound guided approaches as well as fluoroscopically guided approaches. There's external power sources where there's a miniaturized internal receiver or pulse generator, allowing us to cross joints, allowing us to be keeping our patients active without having bulky batteries implanted. They can be totally non-invasive. Some of the work done by Dr. Stats in terms of headaches in vagus nerve stimulation have really caught on in an additional non-opioid, non-medication based treatment for chronic hard to treat conditions. And we talked about ultrasound and fluoroscopic guidance. So next slide. So we're going to go around the circle here a little bit to kind of visually describe some of these devices that are available. So I'm going to start from the upper left corner. These are the externally powered indirect power source devices where the impulse generator can be miniaturized, size of a thumbnail with an external power therapy disc. A lot of these applications and remotes are now embedded in an app on your smartphone device. Just below that, that is another similar application of a peripheral nerve and as well as a spinal cord stimulation platform where the power source is external and the receiver is built into the lead. In the middle here, above, one of the early peripheral nerve, dedicated peripheral nerve stimulator systems where there's a micro lead with these tines that you can introduce utilizing a needle under fluoroscopic or ultrasound guidance, where the external power source is stuck onto the skin using a sticker. And just below that, that is another form of the similar device where there's a micro lead that is coiled in configuration, if you look at it under the microscope, allowing ingrowth of our tissue, preventing infection, introduced through a tiny 17 gauge needle. And lastly, in the right upper corner, this is the external vagal nerve stimulator that Dr. Stats helped develop. And you've heard this in the news several times, not just in the world of headaches, but now even in the world of COVID. And I'll mention that in a little bit. Next slide, please. So I consider this was one of the landmark studies that got people interested in peripheral nerve stimulation. And if you look carefully, 3 of our national spine physicians are on that study. And I remember working alongside Peter and learning about peripheral nerve stimulators and getting inspired about doing clinical trials. So in this study, this is a multi-center trial looking at peripheral nerve application of various pain conditions. And it was a crossover study. Next slide, please. So not just one condition was reviewed. Peripheral nerve stimulators were placed in the arm, leg, as well as trunk for various chronic pain conditions. Essentially, any regional chronic pain condition that was neuropathic in nature with a nerve target. Many of these were done under ultrasound guidance. Next. Through the application of this external power source with a remote, of 150 patients enrolled, 94 patients implanted, After 3 months, 38% of the patients responded versus 10% of the patients that didn't respond. They showed statistically significance with pain relief, and over 30% of the patients who crossed over also responded. And this was the early beginnings of interest and resurgence of interest in peripheral nerve stimulation. And this helped obtain FDA approval and finally led to improved reimbursement schemes so that we can finally get back into utilization of this technology and treatment option. And it led into further involvement in innovation of other devices and technologies. So next slide. So I wanted to kind of just highlight this. One of the early uses of this micro lead that was implanted was for the use of post-stroke shoulder. And what's really interesting is that without having to implant something bulky or into the central nervous system, by stimulating the axillary branch of the circumflex branch of the axillary nerve, we can stimulate the deltoid muscle and prevent or alleviate the pain from post-stroke shoulder. And if we want to just click on that picture there, we'll show that quick video of this drop shoulder. And once the device is turned on, you'll see this deltoid fire, and the shoulder is no longer asymmetric, and it comes up. And patients have reported significant pain relief. And now this is a known indication for treatment of post-stroke shoulder. Next slide, please. And now I'm just going to go through some of my favorite targets. The suprascapular nerve for all the regional and anesthesiologists. This is something that we tend to use as a rescue block for someone undergoing shoulder surgery post-operatively. This used to be done blindly and just dropping a needle right next to the scapular spine. However, it's a very useful target for chronic pain of the shoulder, especially in patients who can't have surgery. And this is a nice target for peripheral nerve stimulation. The suprascapular nerve not only innervates the upper part of the shoulder, but also has innervations to the acromioclavicular joint and glenohumeral joints. So for chronic degenerative joint disease, this is an excellent target. Next slide, please. Combined with the suprascapular nerve, these are sort of comes in pairs in my practice, where targeting the circumflex branch of the axillary nerve is an excellent combination in treating shoulder pain. This has innervations to the lateral portion of the shoulders superficially, as well as the upper arm, but also pain sensory components for the glenohumeral joint as well. This is easily targeted using the ultrasound and one of my favorite targets. Next slide. We all know the intercostal nerve is a very common target for the use of pain control for anyone who has rib trauma, rib fracture, previous surgery, peripheral neuropathies such as post-herpetic neuralgia, and an excellent target for peripheral nerve stimulation, especially when you want to use a minimally invasive option. And certainly ultrasound is a wonderful tool allowing us to access and target these nerves. Next slide. Anyone who has treated patients with chronic growing pain, especially after hernia orphy surgery, this is an excellent option when other more invasive neuromodulation techniques are not available. This is on the right panel, you see a fluorograph of one of my patients who had fairly advanced HIV and who was immunocompromised. And I just didn't think that a centrally placed DRG stimulator would be the best target. So this was done under fluoroscopic guidance, and he was able to avoid opioids and other hepatic toxic medications because he was having some issues with his both hepatic and renal systems, and he did fairly well. Next slide. Anybody who's dealing with peripheral joint and distal distal and joint pain, such as ankle and foot pain, targeting the tibial nerve can treat certain post-surgical conditions. And in terms of patient compliance, it's fairly hard to convince a patient that you need something put in your back when the problem is in the periphery. You know, we all know post-spinal, post-fusion laminectomy patients, they don't mind the concept of putting something in their back for their back and leg pain. But sometimes when patients have no spinal injuries or spinal pathologies, it's hard to make sense when you're trying to treat their foot pain, but you want to put something in their back. So peripheral nerve stimulation offers another excellent alternative. Next slide, please. So here's an interesting study that I'm proud to be part of, along with my partners, Dr. Mack. I think Dr. Patel was also on this study as well, where we looked at post-amputation pain. So this is a very hard entity to treat. It's a challenging patient population along with lots of comorbidities. So utilizing a centrally placed system may not be the best in terms of potential infection risk. So we placed peripheral stimulators targeting both the femoral and the sciatic nerves. And this trial showed excellent results in treating not just residual limb pain, but also phantom limb pain. And in this study, we were able to tease out reduction of opioids as well. Next slide. So this is a placebo-controlled study where we saw significant reduction of pain in patients with this device. Double-blind placebo-control, meaning that even though patients had, they were blinded, meaning that folks had the device placed in, but a lot of times they weren't even active, and the patients were blinded to that, and as well as the physician. Next slide. And an average of 80% average reduction in pain at 12 months in responders. So this was quite compelling results. Next slide. And what's interesting about this is this device was only placed for 60 days. So even though the device was placed for 60 days and it was removed just by pulling on the tiny microlead, patients demonstrated pain relief up to 12 months. So we now know that there may be some lingering effects of peripheral nerve stimulation, and possibly due to changing of the peripheral architecture, the peripheral neural transmitter sort of balance of inflammation, as well as possibly affecting the dorsal column neuroplasticity of the spinal cord. Next slide. Speaking of back pain, this company decided to utilize a peripherally placed device to treat axial low back pain by targeting the multifidus muscle. And this device has recently become FDA approved in this country for utilizing for chronic axial low back pain. And I'll just kind of go through the two trials quickly as well. This does require an implanted impulse generator. Next slide. So first, it was an international multi-center prospective trial and showed at 60 days, there was a 58% responder rate. This was a single arm. There was no control. Everybody got implanted, and they observed how patients did, but it requires an implantation of a device along with a battery. Next slide. This was followed up by a study where U.S. investigators were also included. This was probably an underrated study. They had wonderful investigators on this, well-known investigators on this trial, even though there was no statistical significance shown. But at 1 year, 60% of the patients had 50% or greater in pain reduction. And so I apologize, this slide is not updated to the point where this device is approved as of a few months ago. Next. So rather than implanting a device with a battery, what if we use the same 60-day device, microlead, in the axial back? Would we get similar results? And we did just that. When we thought about this design, I admit I was probably one of the early naysayers saying this could not work. By placing a tiny microlead next to the medial branch nerve in the multifidus muscle, stimulating the axial back to treat axial back pain. But contrary to that belief, we showed that after 60 days, these patients got lingering extended relief even up to 12 months. So this was really exciting data that I'm happy to participate in, and along with my partners in New Jersey, and demonstrated this efficacy. And now it's become a staple in my practice, especially with patients who do not want an ablative destructive procedure on their lumbar spine, or people who are refractory to neuroablation procedures. And this is literally a 15-minute procedure done under fluoroscopic guidance with confirmation using an ultrasound. Next slide, please. So by placing a tiny 30 micron in diameter lead bilaterally targeting the multifidus muscle, and we leave it in for 60 days. Next slide. So here are some results. By leaving this device in for 60 days with utilization by the patient for up to 6 hours at a time, we were able to show that 80% of the subjects responded at 3 months post-study. 50% of the subjects had greater than 50% pain relief, even 12 months after the end of therapy. So on average, 60% of the patients had a reduction in pain in amongst responders. So the question is, well, what happens if after 60 days, when the lead is removed, the pain comes back? Well, you have a couple options. You can wait for the universal period to end and you can place this back, or consider some of the other more permanent peripheral nerve stimulators that I spoke about earlier. Next slide. And this is exactly it. This is one of my patients, a 60-year-old male, chronic low back pain. You can see that he's had a previous laminectomy. He's failed traditional SES, and he was miserable. He was going to the ER. He was on pain meds. So in terms of value-based, as Dr. Gordon mentioned, this is cost. He's going to the emergency room. He's getting opioids. He's getting injections that have very limited pain relief. And lo and behold, I did one of these 60-day device therapy trials on him. He liked it so much, he came in with duct tape around his whole torso because he didn't want me to take it out. So ended up putting in one of these more permanent devices in, which helped his pain. He's no longer taking opioids, and very functional. Before the COVID thing, he was doing driving an Uber car during his retirement as a pastime. Next slide, please. And he sends me pictures once in a while of him climbing and hiking, and this is him on the top of this dune or this trail. Next slide. So I want to end this talk with talking about non-invasive peripheral nerve stimulation. In our practice, many of us, including myself, can't claim that we're headache experts. However, being chronic pain experts, we do come across patients who suffer from chronic headache conditions such as migraines and cluster headaches. And obviously, I have to admit, I had the privilege of working alongside Dr. Statz and definitely learned about this device as it was being developed. Saw his challenges and his heartaches going through the development phases and understanding how hard it is to bring something to market. But this is available to treat patients for cluster and migraine headaches. I certainly offer this to my patients as something that they may be able to bring up with their headache specialist, or I just prescribe it myself. But what's interesting about this device is knowing its mechanism in terms of reducing the inflammatory response, especially in the respiratory system, because it targets the vagus nerve. What is really interesting, and I'm proud that he's part of our organization and my friend, the next slide, you'll see that for those that haven't heard about this, this device is actually, we hear about the vaccines getting the emergency use authorization. In fact, this peripheral nerve stimulator precedes the emergency authorization usage from the vaccines as one of the ways in treating COVID-related respiratory symptoms. Essentially, in the early phases, that cytokine storm this vagal nerve stimulation has shown to decrease this cytokine storm and reduce its effects and the symptoms. And this has been, in fact, utilized on some of our colleagues and in good results. So I'm curious to see what the status of that trial is in the country. So next slide. This is probably something that most of you guys are interested in as well, in terms of, well, no profit, no mission. How do we do this in an efficient and practical way, allowing patients to get results, but at the same time, you have to do this without losing money. So peripheral nerve stimulation, as of beginning of 2019, obtained some very favorable reimbursement decisions. And these are some of the codes that you can use. These are the 2 CPT codes for peripheral nerve stimulation implantation. And in terms of both ASC applications as well as hospital outpatient department applications. So this is something that is not, this is not something you get wealthy off of, but this is something that definitely helps your patient, and it's provides positive revenue source, and it's such an easy and low risk procedure for anyone who does injections, who anyone has ultrasound skills, which is all of you guys. This is something that you can definitely get trained and utilize very, very quickly. Obviously, I'm not a coder or a biller, so I'm going to defer any specific questions to our NSPC billing experts on this. Next slide, please. And as we come to an end on this talk, I want to kind of just review some of the targets. So there are some well-known targets, but obviously anything that you think that there's a peripheral nerve target, I would encourage you to try. And then I think I have one more slide to finish us off. Now that we're coming into the holiday season, I wish everybody a happy Festivus. I want to kind of just review in terms of the number of population of patients in America that suffer from chronic pain. We're coming out of a pandemic and still dealing with an epidemic in an aging population with comorbidities. Sometimes spinal cord stimulation may not be the best. So peripheral nerve stimulation is a cost-effective alternative. It's low risk, has level 1 evidence, and has favorable reimbursement. So who better to say it than my favorite Festivus enthusiast, Mr. Cosenza himself. So with that, thank you, Peter. And again, I want to thank everybody and I wish everybody happy holidays.
Thanks, Sean. That was a wonderful presentation that in a relatively short period of time, you've kind of condensed the world's literature of peripheral nerve stimulation, which is, I think, one of the very interesting and evolving areas of medicine. We do have others that are down the road, evolution of spinal cord stimulation. We have regenerative medicine, which will be dealt with on an upcoming panel, but this one was a wonderful job. I'm going to, anybody may want to ask a Q&A. Right now, there are no questions in the panel, in the list, but please feel free to ask questions. Let me throw a question out at you. You mentioned that in 1965, Melzack and Wall came up with the gate control theory, and that was part of why Sweet and Long and others actually developed the first peripheral nerve stimulators. You're stimulating a fiber, you're turning off another fiber, and in fact, which is the pain fibers, and you need to have the stimulator on to control pain. But what you just described in the last third of your presentation is that you can actually stimulate a nerve and then have relief for 10 months at least. Why do you think that is?
If I knew the exact answer, I probably don't have to work anymore tomorrow morning. But I think there's a lot of theories. Just learning from the experiences of spinal cord stimulation, we know that over time, the dosages decrease. There may be some effects both centrally and peripherally that we're changing the behavior of nerves. We're restoring the neural inflammatory state of the nerves. I know topics about neural inflammation is a widely talked about controversial topic these days. So a lot of these things can happen. But what's interesting is we know we can stop the functioning or the transmission of signals in a nerve with local anesthetics, but we can do the same thing with electricity. Utilizing these high frequency neural link cuffs, this definitely other companies have come along, being able to use a pulse of stimulation to essentially turn a nerve off. But now with these other PNS devices, we may be changing the behavior of the nerve over time and maybe restoring their function. So all those things, I'm much, an enthusiast in following that data. Certainly there's lots of basic scientists working on this. And I think this is, we're still in the infancy, and this is the peripheral nerve renaissance.
I would suggest that there's a couple of things that we didn't really anticipate when we did this. One of the things that you've talked about is, you can do a local anesthetic block, and if that block takes away the pain, then you go off and do a peripheral nerve stimulator. Way back when in the OnStim study, that's what they did to determine for occipital neuralgia. They did a block if they did better. But what they did was they took that population of patients who failed the local anesthetic block, and they then went in and followed them separately, and they did better or just as well. So I think there's something to activating a nerve as opposed to blocking a nerve. And there may turn out to be poor correlation. And you kind of alluded to that. You may want to go ahead anyway. And I think that's a good point. Second point that I would suggest is that so then you have to ask the question, why is it that historically we didn't see these long-term results if the battery died or something like that? And I think that's probably due to the location of the electrode placement. What we're doing now with this micro electrode is placing the electrode distal to the nerve, creating an electric field that is probably activating sensory nerves, which have a different threshold than other nerves. And we're probably able to activate areas of the brain and remodel the brain as well as the spinal cord, as you mentioned. So that's my view on what we're doing there. But it is substantively different than what we thought about 55 years ago. So it's just an interesting, as you point out, evolving field. But wonderful presentation. And let me check our time. We are very much over. Let's just see if anybody has any burning questions. Really no burning questions. So to fill out your CME, here you go. Here's the activity to go for. And I'm going to end with Dr. Lee's done his damage or done his duty to us twice, right? Or have I tortured you 3 times?
Twice.
Twice for this one. Please email me if you're interested in talking about any aspect of interventional pain management or pain management in general that you feel is relevant for our entire group. And we'll figure out how to get this integrated like Dr. Patel did. So with that, I think I will speak with you all again for our holiday cheer party. But if I don't see you again, have a wonderful holiday season. Merry Christmas, Happy Hanukkah, Happy Kwanzaa, Happy Festivus for the rest of us. So
The rest of us.
have a great night, everybody.
Good night, everybody. Good night, Peter. Thanks.
Night. Thanks, Sean.